Hello, listeners. We're back with you on Views on Health. And this Monday, we have the pleasure of having with us once again Dr. Nilangika Sandakumari, consultant physician and head of the Department of Pharmacology, Faculty of Medical Sciences, University of Sri Jayawardhanapura. Dr. Nilangika Sandakumari discussed autoimmune diseases the last time around, and we're going to continue on the same topic but focusing on the treatment of autoimmune diseases. Over to you, doctor.
Yes, thank you very much. So last time we had a look at autoimmune diseases, just an overview. What are they? What are the causes? And what are the symptoms? And what is the natural cause of autoimmune diseases? Today I thought of discussing a little bit about drugs available in the management of autoimmune diseases. So I hope you can remember last time also I have mentioned that autoimmune diseases, they don't have a permanent cure. What we do as treatment is control of this overactive immune system and bringing down the inflammation. So the pain and inflammation becomes less with treatment. So we have wide variety of medications to treat and control the symptoms. And one of the simple medications available are called non-steroidal anti-inflammatory drugs, NSAIDs in shortened form. I think you all must be very familiar with these sort of drugs because you use them on a daily basis for pain control, even for simple headaches. Some people tend to take NSAIDs. Celecoxib, diclofenac, these are examples for non-steroidal anti-inflammatory drugs. Non-steroidal means they are not steroids, but they will reduce the inflammation. So they can be used especially in conditions where arthritic pain, in rheumatoid arthritis and joint pains can be controlled with non-steroidal anti-inflammatory drugs, and patients will have less swelling, pain, and their quality of life can be enhanced with this sort of drugs. But when NSAIDs are not that effective, and although they reduce the inflammation, they will not retard the progression of the disease. They will just control the symptoms and reduce the inflammation. But the joint damage or organ damage caused by these autoantibodies are not controlled with this diclofenac, celecoxib group of drugs. So you need to start your drug on concomitant other drugs to control the disease progression. So these drugs are called disease modifying antirheumatic drugs, DMARDs in shortened form. So you need to start them as well in your patient at an early stage to retard the progression of the disease. So we will discuss about DMARDs in detail, but before that, I need to tell you about steroids also. Now, steroids, I think most of the patients must have taken steroids at some point of their lifetime because they are commonly used in multiple other medical conditions also. Steroids include prednisolone, hydrocortisone, dexamethasone, and widely prescribed in a lot of other medical conditions. So steroids will control the immune system and it will lessen the overactivity of the immune system and limit the disease progression. So steroids, when the patient is prescribed steroids for an autoimmune disease, there are specific instructions you need to give your patient. Otherwise, the harm will be more than the benefit that it provides. So what we need to tell our patient is Now, these sort of diseases needs to be treated with long-term high-dose steroid therapy. So then the side effect of steroids can be seen in these patients. Now, patients who are on long-term steroids can be identified at a glance. They will have, their faces will become round and puffed up, and hair growth in their face we call it hirsutism. It can occur in excess. Their the skin can become, we call them striae. Rupture of skin can give rise to striae, and their limbs, skin can become very thin, and blood pressure levels, blood sugar levels can go up. So all these needs to be monitored. And steroids can affect the bone mineral density. Bone calcification can get affected. So patients who are going to get long-term high-dose steroids therapy need to get specific bone protection drugs also. So we will give them once a week a pill to protect their bones. Otherwise, they will get fractures with even minor degree of falls. So they need to minimize falls and get the medications that are needed to prevent osteoporosis, and bone mineralization has to be maintained by taking a pill once a week. And again, their eyes are affected by steroids. Prednisolone long-term, dexamethasone long-term can cause cataract in eyes and glaucoma also. So visual assessment needs to be done frequently. And also patients now, when they are receiving treatment with prednisolone for a long time, their immune system is suppressed. So they are more prone to get infections. So they should be advised to avoid crowded places. And now in these days where COVID-19 is more prevalent, they must take all the health precautions and avoid people with positive COVID-19 test results. And also they cannot receive live vaccines. Live vaccines also have the organisms half killed, so the disease can occur in them because their immune system is suppressed. So they should be advised not to take live vaccines. And one other important thing is, when we prescribe steroids for a long time, our body's ability to generate its own steroid hormones become lesser. So in our body we have adrenal glands. Adrenal glands are the ones which will generate steroid hormones in our body. So if you give steroids as tablets for a long time, your adrenal glands, they also become suppressed and they will lose their ability to generate steroids in the body. So then if you suddenly stop steroid treatment, you can become critically ill because you don't have endogenous or inbuilt steroid hormones in your body. So your patients must be advised not to abruptly stop steroid therapy. If you want to stop it, it has to be gradually tapered off over a period of time. Now suppose now the patient is on 40 milligrams of prednisolone in the morning. So we need to continue it for about 2 weeks and then reduce it into 30 milligrams in the morning for the next 2 weeks, then 20 milligrams, 10, 5 every other day, and then you stop. It has to be a very gradual decline. If you stop prednisolone suddenly, then your adrenal glands will not produce enough hormones and the patients will collapse. Their blood pressure will drastically drop, their sugar levels will drop, their salt levels will drastically change, and they can collapse. It can be life-threatening. So it's very important. Taking prednisolone, dexamethasone or any other steroids over the counter is not advisable, especially in conditions, autoimmune conditions where you will be given very high doses of prednisolone. You need to adhere to your doctor's plan of management, and it has to be gradually reduced and tapered off. All the adverse effects such as high blood sugars, blood pressures, they should be monitored and screened time to time. It's a very important message that we must convey to our patients.
Thank you once again, Doctor. And interestingly, I was going to focus on self-medication, because some people, with due respects to our listeners out there, do have a tendency to self-medicate. They go and see the doctor, they're diagnosed with whatever the ailment is, they're put on treatment. Then this is something that we've discussed in past programs as well. They get better, they stop treatment altogether. And then if they suddenly get a relapse, then they think, oh, I have the prescription, let me buy and start all over again without even consulting a doctor. Then some others, anyway, will continue without consulting a doctor. So that now, like you said, if you're gradually reducing the dosage, they won't be doing that, they'll be taking the normal dosage. The danger is there.
Yeah, so that is very important, especially with regard to autoimmune diseases where steroids are used and also other cytotoxic drugs. Now, the other drugs that we used in the treatment of autoimmune diseases, we call them cytotoxic drugs. Cyto means cells. Cells, toxic. So these drugs are toxic to cells. If you take them without proper supervision, your cells are going to get affected. It's not only the immune system, but all the rapidly dividing cells in the body will get affected by these drugs. Now I told at the beginning about disease-modifying antirheumatic drugs, DMARDs. One such drug is methotrexate. You may have heard of or you may not, but that is a commonly prescribed drug for rheumatoid arthritis and other autoimmune diseases. We give it as a once a week pill, usually on Wednesdays, along with another folic acid tablet on Sunday. And patients, when they are taking these tablets, need to be monitored very carefully. Otherwise, it can damage patients' other systems also. Now, these drugs are targeted against the rapidly dividing cells in our body. But apart from the targeted cells, these can affect other rapidly dividing cells. For example, our hair follicles are rapidly dividing. Gut epithelium, rapidly dividing cells. Bone marrow, which produces blood cells, have rapidly dividing cells. So these sites will get affected by this drug. So if you continue to take methotrexate without monitoring these, now for example, bone marrow function can be monitored by doing a full blood count. So without monitoring full blood count, you can't continue methotrexate. If you continue it without monitoring, your bone marrow suppression will not be detected. And until you get a severe sepsis and until you become severely ill, you don't know that your bone marrow is suppressed due to methotrexate. So when these drugs are started, you are instructed to monitor your full blood count, your liver functions, kidney functions. They all needs to be monitored time to time. So it's very important to adhere to your doctor's plan and must take the pill on the day that he advises you to take. Usually it's on Wednesday every week. And Sunday you need to take folic acid. They both should not be taken together. If the folic acid is taken on the same day with methotrexate, the drug will not work properly. Now some patients, when we prescribe methotrexate and folic acid on 2 separate dates, they take it on the same day. Then the drug will not work. it has to be given on 2 separate dates. And when you are asked to come back to the clinic with full blood count or liver functions, you need to do them and go. Because methotrexate can suppress your bone marrow, and bone marrow is the place where your white cells, platelets and red cells are generated. So if your bone marrow is suppressed to a higher degree, your red cells will become very low and you will become anemic. If your white cells become very low, then you will easily catch all the other infections and you will get mouth ulcers and all that. And platelets, when they become very low, you may spontaneously bleed. So very important to monitor blood counts as your doctor instructs you.
Doctor, just for our information, why is it Wednesday and Sunday? Can't it be Monday and Thursday, for example? I'm just asking.
Yeah,
and also, doctor, is that like across the world? Is it Wednesday, Sunday when you treat such patients?
Yeah, it's something like, it's a tradition, I would say. You can take it on Monday and Thursday also. But there should be a gap. This may be a little bit more for our listeners, but since you asked, if I may explain the rationale for keeping a gap. Now, methotrexate is a drug which will inhibit or which will prevent our cell now cells will divide, and that division will need folic acid as a for the cell division you need folic acid. So this methotrexate will prevent the active generation of active form of folic acid. So by that it will prevent the cell division. Now if you give folic acid along with methotrexate, however much folic acid prevention is acid synthesis is prevented by methotrexate, that folic acid that you give from mouth will again replenish the stores, so the drug will not work. But why do we need to give it on a separate date? That is, the methotrexate, which will affect all the folic acid stores, will affect the other healthy cells also. So to replenish the stores in the other healthy cells, we will give it on a separate date. Don't take it together, give it on a separate date. That date you can take it on Wednesday and Sunday, or you can take it on Monday or Thursday, but the tradition is to give it on Wednesday and Sunday.
Thank you for clarifying that. I guess from the physician's side, it's much easier across the board to monitor. Wednesday, Sunday, we are done with it. That's it. I just wanted to check.
Yeah.
Definitely the gap has to be there.
Yeah, and the other thing is now in our culture, sometimes patients do not know the tablet they are taking. Name of the tablet, patients do not know. So sometimes we ask from the patient, what are the drugs that you take for your rheumatoid arthritis? And they tend to say, I'm taking the weekly pill that is given on Wednesday. But he cannot recall the name. He doesn't know whether he or she is taking methotrexate, but she knows that she is taking a pill on Wednesday and another pill on Sunday. Now, any doctor, when the patient says, I'm taking a pill on Wednesday and pill on Sunday, then the doctors know the pill is methotrexate with folic acid. That's why as a convention, we give it on those 2 days. Patients do not know their names, but when they say the days that they are taking, we know that the drug is this one.
Thank you so much, doctor. So as you explained, sometimes you reduce the drugs over a period of time. Will there be necessity to increase it?
Yes, of course. Now, when the disease control, now this has to go in a stepwise manner. The initial treatment is with a steroid and a drug which have least side effects is started initially. And then you monitor the progress of the disease. Now, suppose your patient with SLE initially came to you with some skin rash, joint pain, and minimal symptoms. Then you have started on steroids and a mild mild other cytotoxic drug. But in few months time, the patient comes to you with involvement of the kidney also. Then you can't reduce the drug doses. When the kidneys are affected, you have to escalate the treatment. Then you have to add some more cytotoxic drugs into your regime. Now, for the interest's sake, if I am going to name few such drugs, you have some drugs called cyclophosphamide, may be very new for the listeners, but just to know, and MMF. These are highly toxic with lot of adverse effects, and we use them just to control the flare, and as at the earliest opportunity we stop the drug. These drugs are administered usually either in the hospital as pulse therapy or as tablets, but given for a minimum period of time and then stop it as soon as possible. They are very toxic. And the patients who are on MMF, cyclophosphamide, even methotrexate, must not get pregnant. Pregnancy is an absolute contraindication while on these treatments. If the patient becomes pregnant while on treatment, it can cross the placenta and can form severe deformities in the fetus, in the baby. So, patients must use a effective contraceptive method during the time of the period of treatment. Not only during the period of treatment, but for 3 months after the treatment course is completed, for the next 3 months, until all the drug inside the body is washed out from the body, patient must take effective contraceptive method to prevent damaging the baby. So, yes, sometimes you can reduce the dosage regimes, but sometimes we may have to escalate treatment and give such highly toxic drugs for a short period of time to control the patient's symptoms.
Thank you, doctor. And focusing on the pregnant woman, can a woman have a baby, the first child, and everything is okay, and she delivers a baby? Now, before she becomes pregnant for the second time, can she develop any of the autoimmune diseases? And then you start your treatment as a result.
Yes, that's a possibility. There are such patients. For the first baby, they may not have had any symptoms. But before becoming pregnant for the second time, they may develop an autoimmune disease. So then you wait until we achieve a remission and then allow the woman to become pregnant.
And one final question, doctor, because time has caught up with us. You did say that this condition is fairly common the last time around. And do you see this increasing in your practice? And if so, what is it that makes more of women of this particular age group, the childbearing age group, be prone to autoimmune diseases, as well as others who also can have the same problem in the course of their lives?
Yeah, so we see increasing number of patients with autoimmune diseases nowadays when compared to the previous days, but there can be multiple causes for that, because medical diagnostic methods now are widely available, and it's rapidly advancing. Diagnostic methods investigations are evolving, so we may be diagnosing more frequently than we did it before. And the other thing is, now I said during last discussion also, we don't know the exact cause for autoimmune disease. Maybe due to chemicals, maybe due to dietary changes. Now Western type of a diet, which is very high in fat, starch and all that, they trend like that sort of a diet increases the tendency to develop inflammation within the body. So now our people are also following, most of them are also following Western type of diets. So that may be risk factor for increasing number of people with autoimmune diseases. But all these are hypotheses, still under investigation. So yes, the number of autoimmune diseases are increasing, patients with autoimmune diseases increasing, but the exact cause still not known. Maybe changing dietary patterns, infections, and exposure to chemicals. Everything must be contributing.
Thank you, Doctor. And there we end yet another interesting discussion. And this was on the treatment of autoimmune diseases. Thank you so much to Dr. Nilangika Sandakumari, consultant physician and head of the Department of Pharmacology, Faculty of Medical Sciences, University of Sri Jayawardhanapura, for being with us on the program and sharing your expert knowledge on this topic. Thank you, Doctor. Thank you also to Malinta Deshapriya for technical assistance. I'm Fatima Razikada saying good night and hoping to catch you next Monday same time on Views on Health.